those. So we're going to be focusing a lot today on CSFs and all the characteristics needed. So we're going to be talking about bacterial, viral, fungal, and things of suspected meningitis when it comes to CSFs. Okay, so here's our clinical introduction scenario. A 43-year-old presents with fever, neck stiffness, and altered mental status. Blood cultures are drawn, and a lumbar puncture reveals cloudy CSF with elevated white blood cells and a low glucose. Gram stain shows gram-positive cocci in pairs. The provider initiates empirical antibiotics for bacterial meningitis. Prompt specimen collection and interpretation of CSF and blood microbiology culture. Results guide life-saving treatment. Okay, so here's our agenda. Like I said, we're going to be going over lecture 1 and 2 today, 3 and 4 tomorrow, and 5 on another day. All right, so these are just some general guidelines, general considerations when providing these microbiology specimens to the lab. You also got to take into account timing. You usually want it in less than 2 hours. Volume, depending on what the type of specimen is, proper transport, and critical findings. So that's really what we're going to be talking about today. So here is our first important slide that I want you all to star. All right. It is important that when you have an active disease site that you are collecting from that. So either that's by a swab, that's by taking a sample of it. If it's a sputum, ensuring that your patient is providing that sputum sample into that sterile container. All right, you want to avoid contamination because contamination can get mixed, that normal flora can get mixed in there. We can have some incorrect results, okay? You want to make sure that their containers are sterile, especially for your fecal specimens. Accurate labeling. Usually in BAMSI, they want a minimum of like a name or a social or a name of a birthday. But for microbiology, you want to add that additional source and the date and time of collection. Also, always take precautions. You use those universal precautions. Just assume that everybody's infectious, right? So you always have gloves. You got your proper masks on. And then lastly, you want to take into account their travel history if it's relevant to a pathogen that you think that they have. Right? Timing of collection. Yeah, this is also an important slide. All right, so viruses collect during that acute phase. So when they're having those active symptoms, that's when you want to collect. Bacteria, it is imperative that you collect whatever that is, CSF, fluid, blood, feces, prior to giving them any medication, okay? Parasites may vary, and then fungals, it says no special guidance, but each MTF or each lab will have their specific guidance on how they want their fungal specimens provided to them. Make sure that you are providing a sufficient volume for all those tests to be ordered because you do not want a quantity not sufficient. You do not want to call your patient back in to collect more. They hate that, and we hate it too. And then for tissue or fluid aspirates are always beads and swabs. So if you can get something in a cup for us, we would appreciate that. But if not, if you have to do a swab, we'll do what we got to do. We'll do our best to get you the result with what you all provided us with. Okay? So here's that proper transport. This is another important slide for you all to know. Okay? Transport media. So all viruses will be transported in what's called you use a VTM swab. So that Kerry Blair is for the stool. And for parasites will be a formalin or PVA. Also for stools if you're looking for parasites. So you see on that top corner there that is a biohazard bag, and it looks like there's some type of sample, some type of liquid sample. Please make sure that you're submitting, when you submit your labs, you're using these biohazard bags. Please don't submit with no paper bags or Ziploc bags or wrapped up in a glove. Please don't do that, okay? Biohazard bags, please, okay? Specimen handling delays. If there is a delay, make sure that you're at least placing them in the refrigerator. And if it's you don't have a fridge, make sure that you're holding it to about 2 hours max. If there's anything after that, we may have to reject it. So get it to us as soon as possible. So these are critical findings. I will not test you on this, but this is just letting you know that if we find these in the labs, we will make sure to get a hold of you all. So we're either sending somebody to you or we're calling you and we're letting you know this is what was found in the samples that you provided. Okay? slide, however, I do want you to know because the big one here is that group B streptococcus. Group B strep or Streptococcus alcalatiae during pregnancy. So this is that presence of Streptococcus alcalatiae bacteria, and this is why it's important is the prevention of neonatal sepsis. So why is it important if you have a pregnant woman and she does come up positive for group B strep? Why is that important? Correct. So make sure that you're providing her those antibiotics before she delivers that baby. Yep, y'all got this. All right. So unacceptable specimens. I still don't know what this thing is kicking. It looked like a zebra cake or some shit. I don't know what that is. What is it? What is it, y'all? I don't know. It's a what? It's a zebra cake. I said.
No one will kick a zebra cake.
I know, right? That was weird. But yeah, so unacceptable specimens. Improper labeling, wrong container swab, leaking, late submissions, and quantity not sufficient. Okay, blood. You know we love to talk about blood and lab, right? So while we collect it, we're to diagnose bacteremia, endocarditis, or sepsis, and timing is crucial. Make sure you're getting that blood to us before giving them antibiotics, okay? All right, so in any blood cultures per episode, you want to have 3 to 5 sets per episode, and pretty much we need a set for aerobic or anaerobic testing. So we want to have 2 sets from different sites, and one additional set after 2 hours. Okay, if 2 or more sets are negative, then you want to collect 2 more, 24 to 48 hours if endocarditis is suspected. So if you have 2 more sets of cultures that are negative, after how many hours do you collect more if endocarditis is suspected? 24 to 48 hours. Make sure you're highlighting that, okay? You'll see it again. All right, so here's that visual. I tried to explain it, but maybe the visual will be a little better. All right, so blood culture protocol in adult patients, okay? So you suspect that your patient has endocarditis. All right, you're gonna take 2 cultures on the left, 2 cultures on the right, aerobic, anaerobic, aerobic, anaerobic, okay? 20 mLs. And this is what those blood culture bottles look like. So there you see the adult, that blue is that aerobic, the red is anaerobic, and then the pediatric is the yellow. So you want to have 20 mLs for adults and a maximum of 4 ml for pediatrics if possible. Okay. Yes.
You said we're taking 2 from each arm.
Correct. Yeah, they have 2 sets, right? So you're going to have an anaerobic aerobic on one, or an anaerobic aerobic on the other.
Imagine we'll go into why that would be different, why we're taking from one arm and the other arm.
Yeah, I'm sure there is, and I probably need to research that for you, because I don't go into that. But I will write it down though.
It's just
For contamination.
Different sites, so in case you have contamination over here, you still have a good set over there, so if you do pop positive on both, you know which bacteria it is.
There you go. See? Come up here and teach class. No? Okay, this is just FYI, this is just a guideline that is currently being used. You will not be tested on this. All right, blood contamination and infection risks. All right, so infection risks are high in patients with those prosthetic devices, catheters, and those that are immunocompromised. All right, the coagulase negative staphylococcus is normal flora, but it's the leading cause of those nosocomial bloodstream infections. And y'all know what nosocomial infections are. Hospital now, right? Yeah, those inpatients, correct. All right, so this is saying the impact of contaminations costs $6 billion a year, and then you have the antibiotic resistance, where the MRSA, methicillin-resistant Staphylococcus aureus, resistant strains comes from, and then when you have contamination, there is an increased workload. Okay, so because it's the money slide, you know this is important. You will see this breakdown on your test, okay? All right, so for coagulase negative staphylococcus is isolated from 1 or more blood cultures, and you are suspecting a systemic inflammatory response syndrome. Those 3 criteria there is what you're looking for. a temperature of less than 36 degrees Celsius or greater than 38 degrees Celsius, a heart rate of greater than 90 beats per minute, and a respiratory rate of greater than 20 per minute, a white blood cell count of greater than 20,000 or less than 40 grams per liter, or greater than 10% immature neutrophils, okay? If that's what's seen and that person has a central venous catheter and it's a yes, you have one positive blood culture per episode and they have less than 2 CR symptoms, then it's probably a contaminant. But in that positive blood culture, if you have 2 or more of those SIR symptoms, then you know to treat, okay? So you think they have SIRS, central catheter. If it's no, and there's 2 or more positive blood culture contaminations, you know to treat. But if it's 1, and they have 3 or more to treat, if it's 1 positive blood culture with 2 or less SIRS symptoms, it's probably a contaminant. So I'm not asking you to memorize this. You will have it on your test, but you'll have a question, and just make sure you understand this algorithm so you know how to properly answer the question, okay? Here's a check on learning. Which of the following organisms is likely a contaminant? Yeah, Staph aureus. All right, septicemia and meningitis. Septicemia is a severe bloodstream infection that can lead to multi-organ damage or CNS infections. And meningitis is the inflammation of the brain or spinal cord, often the complication of septicemia. All right, and here's some other CSF. This is an important slide, so make sure you're starting this as well, okay? When you see an increased amount of white blood cells called pleocytosis, there will also be an altered glucose and protein ratios. The glucose balance in a CSF glucose is approximately 60% of blood glucose, and then CSF glucose adjusts to blood glucose within 30 to 45 minutes after the actual lumbar puncture. Okay. So when you compare CSF and blood glucose, the draw blood within 30 to 45 minutes of a CSF collection. If that CSF glucose is decreased, you think infection, think bacterial meningitis, and this will require a blood culture. The CSF glucose is high, it's usually due to hyperglycemia. So here are some CSF characteristics. Normal CSF is supposed to be clear. So if we see something that's turbid like this, like that one that's labeled with A, we're thinking some type of infection. More than likely bacterial meningitis. And then we have another term called xanthochromia, which has this pink or yellow discoloration. As you can see on these 4 on the bottom, they have that slightly pink to it. That means that there's red blood cells that are broken down in that CSF, and we're thinking of some type of suspected subarachnoid hemorrhage. All right, and so to tell the difference between what is an actual traumatic lumbar puncture versus xanthochromia, here's the breakdown here. All right, so anytime you're collecting your CSF, you want to ensure that you're providing 4 tubes. Each of those tubes have to have 10 drops of CSF each for approximately 0.5 mLs. All right, if it's an accidental puncture or traumatic puncture, you will see the discoloration that'll occur amongst those 4 tubes. So you'll have that first puncture will be really red, and then subsequent tube, it'll get a little lighter. So that's how we'll know that there's more than likely a trauma that occurs. Also, when we get those in the lab, when we get those tubes and we spin it down and we see that all the red blood cells fell to the bottom of those tubes and the supernate is clear, that lets us know that that was probably some type of traumatic extraction or puncture. But in SAH, you'll see that yellow colored or even that light pink colored discoloration amongst all 4 of the tubes. And so we're thinking, okay, suspecting some type of hemorrhage going on with your patient. Also, when we look at it under the microscope, we don't see those intact RBCs. It's just kind of like a pinkish, reddish look underneath the microscope, okay? Yep, know that slide, okay? All right, so this is just breaking down.
Man, we lost that
Yes.
projector.
Oh, we sure did. What does that mean? slide that wanna work?
I think it's too high. Put the warning signal back on. Yeah, it says temp indicator. Jeez.
All right, so when collecting a CSF, how many tubes do you need to collect? 4, and how many drops in each of those CSF tubes? 10 for approximately how many mLs?
5.
All right, and the difference between a traumatic lumbar puncture versus hemorrhagic? What are the difference? Red. Uh-huh. Meaning the traumatic one will have more blood in that first one. Mine with the hemorrhaging, you're gonna have that pink that's gonna be in all 4 of those tubes. And now this just don't wanna work, yeah. Is there any way you can like cock your neck this way? Is that okay?
Well, we just have the recording.
You as well?
We have the recording here. But
Okay.
it's fine.
That's right, I keep forgetting it's being recorded. Ooh, I gotta get myself together. Okay. All right, other body fluids. Okay, so we talked about this. Yeah. Any questions? All right, so if the lab report is xanthochromia, then what? We'll review the red blood cells count in tube 4. So we'll take that 4th one. We'll look at it. We'll run some more tests on it. Probably do a CBC. We'll also do some chemistry panels on it as well. We'll check for bilirubin, and then for you all, the providers, you will order some additional imaging testings and consult neurology or neurosurgery. All right, so you see that money slide, so you know that this is an important slide. And we talked about white blood cells and the types of white blood cells in block 1, right? So PMNs are associated with what type of infections? Bacterial. Lymphocytes are associated with what type? Viral. And then eosinophils, parasites, parasitic. So down on the bottom there, it looks like it's a gram stain with gram-positive cocci. And y'all remember what y'all talked about it in microbiology in freshman year about what gram-positive cocci look like? They're purple and they're circular, right? Dark purple, circular, gram-positive cocci. All right, so other body fluids again, we're still talking about CSF. So PCR panel for meningitis and encephalitis, we do within 1 hour. We're gonna talk a little bit more about PCR a little later, but it's just kind of an intro to it. And then when we talk about stat tests, gram stains and PCR, we will get those results to you within the hour. And this provides that quick assessment for signs of infection so you can go ahead and quickly treat your patients. In a CSF culture, we use a Petri dish. This usually takes about 24 to 48 hours for that bacteria to grow. Okay. And that is just another visual for all those visual learners that like pictures. All right, so CSF analysis considerations, 10 drops of blood, 0.5 mLs for each of those 4 tubes. Right, tube 1 is going to chemistry, so we're running glucose, proteins, other chemical tests. Tube 2 is going to micro, that's where we're going to do our gram stain, cultures, and PCR. Tube 3 will go to hematology, where we're looking at white blood cells, red blood cells, and any type of differential cell counts. And then lastly, we have that optional tube 4. A lot of times if there's something going on, we usually will split it amongst the different benches in the lab if we need additional samples to run those labs. So key here on this slide, the gold standard for bacterial meningitis diagnosis is 24 to 48 hours. So what is the gold standard for bacterial meningitis? 24 to 48 hours, okay. PCR is done within the hour, okay? And positive PCR leads to immediate antibiogram-based treatment. We will talk about antibiograms on our last lecture, lecture 5. All right, so we have other fluids, synovial, which is located where? Joints, pericardial, heart, pleural, lungs. Okay, so joints, heart, and lungs, 1 to 5 mLs is what we need. For peritoneal, where is that? Yeah, need about 50 mLs, okay? All right, infectious arthritis. I think we're gonna get more into this, you all. I think you all talked about this a lot in radiology. Just for the sake of lab, just know that what we need to know from you is that you collect the joint aspiration from the synovial fluid. We'll look for different bacteria. We'll see that and look for sepsis in there. Okay. Infectious arthritis typical presentations. Your gonococcal arthritis is caused by that Neisseria gonorrhea infection. The non-gonococcal arthritis caused by various microorganisms and cause severe joint damage. And then infected artificial joints. These are found in those with those prosthetic joints. I won't touch on that, so don't worry about it. Synovial fluid, lab workouts. We'll do PCRs. We'll detect pathogens and infections, arthritis. And the gram stains will provide our bacterial presence within that joint fluid. So what's key here is that we use polarized microscopy. So pretty much we're looking at this under a microscope. That's what that means. And when you think your patient has gout, sometimes there's gout and there's pseudo gout, right? So gout has those MSU crystals. MSU crystals are they're like needle thin, they're bifringent, meaning when we look at them under the microscope when we're trying to focus, they do not refract back to us. But in pseudo gout, you have these CPPD crystals. Those are rhomboid looking crystals. And when we try to focus in and out, they provide like a refractile back to us, so we know that's pseudogoid. Pseudo gout, okay? So make sure that you're knowing the difference between the MSU and the CPPD in a patient that you suspect has gout, okay? Osteomyelitis, purulent bone infections. I think you're gonna get a little bit more into this when you do your, I think in senior level, we're not gonna go too much into this. But for the sake of lab, you can collect different synovial fluids that will take a lab and do bone biopsies that we sent for culture in histo. And in histo, pretty much you'll take a sample. In histology is pretty much where you're taking samples of tissue, and that tissue is taken back, put into some wax, and that wax is then put on a machine and cut very, very thinly, put on a slide, put some stain on it, and then we look at the characteristics of that tissue. That's pretty much what histo does. All right, and so you've seen this list. I will not test you on what this is. You already did that in micro, okay? Freshman year. Tissue biopsies, like I said, histopathology. You all will provide tissue biopsies either by scalpel, punch biopsies, shavings, things like that. You'll get a little bit more into that maybe into derm as well in your senior year. But I do want you to know this slide, okay? So just know the difference that's between a scalpel and razor blade. Those are used for superficial biopsies, and there's a video attached if you want to take the time to watch that. And then you have your punch tool, which is a deeper sampling for histopathology, okay? So superficial versus deep sampling depends on the clinical need, and then the diagnostic value of the tissue structure examined ensures accurate diagnosis. So know the difference between the two. Respiratory tract infections. Pathogens can be present even if that patient does not have any symptoms, right? So your upper respiratory infections, those are very common in the children, RSV. And then your lower respiratory infections are less common but can be more severe. So PCR detects the viral and bacterial DNA. You do culture and sensitivity, which confirms those bacterial infections, and then blood cultures. Right? So point of care testing, screens for RSV, S. pyogenes, flu, and COVID. A lot of times that's just a quick swab right in the nose. And of course, this is point of care. You or your medics will be the ones collecting those and sending it to us. Then we have serology testing, which detects antibodies You have your urine antigens, what identifies Legionnaire, S. pneumoniae, and comprehensive diagnostic testing, where you can have a combination of complete blood counts, comprehensive metabolics, or arterial blood gases for accuracy. So just as like in this last test where I was providing with a lot of different panels, that's the type of stuff you'll get back on your patients. So you got to be able to distinguish what is important, what do you need to extract from that, right, to diagnose your patient correctly. Right? Just know for respiratory tracts, you use the nasopharyngeal swabs and transport media or saline. So each one of these has, I think, the nasopharyngeal aspirate washes. It's pretty, I don't know, the video kind of gives me heebie-jeebies, but they stick the swab all the way down the patient's throat, swab both nostrils, and then you just take that aspirate, you take it and aspirate it to some saline, and then provide it to us, right? And we will go ahead and test that. Then you have your nasal swabs, which just kind of get right into the skin, right underneath, right in the nose, and then you have throat swabs, which we use for group A streptococcus. Now, in children, it is important to rule out group A streptococcus pyogenes or gas. Okay? This prevents complications like rheumatic fever, post-streptococcal glomerulonephritis, nephritizing fasciitis, and or toxic shock syndrome. All right, so this is an important slide. And so pretty much what I want you all to get on here is that if you do a throat swab, right, on an adult patient, it's negative, do not treat. If they are positive, you treat. But in a pediatric, less than 16 years old, even if that rapid test comes back negative, you also want to do a culture on that child just to rule out that gas, that group A strep as pyogenes, okay? That's the difference between the adult and the pediatric patient, so know this as well. All right, so for lower respiratory tract sampling, you have your sputum and tracheal aspirates for pneumonia investigation. You have your bronchial lavages or BALs. This identifies pathogens, pneumonia in ventilated or immunocompromised patients. And this is pretty much your assessing the quality of respiratory culture. And in specimen, sputum specimen grading, we use the Bartlett scale. And this is used to determine if the sputum sample is suitable for lower respiratory infection diagnosis. And in the Bartlett scale, we're looking for PMNs, or those neutrophils, mucus strands, and squamous epithelial cells. All right, if the score is greater or equal to 1, this is a valid sample, this is suitable for culture. And if it's less than 1, it is a contaminated sample and will need to be recollected. So here on this slide, it's just showing the criteria that we use for this Bartlett scale to assess that sputum quality. And so these two pictures that you see, this is what we will see in the micro lab. This one on the top has a lot of mucus, it's very mucousy, there's a lot of white blood cells, but there's not a whole bunch of bacteria. And then this one on the bottom is a lot of white blood cells and a lot of bacteria in there, okay? So the one on the bottom, actually both of these would meet that sputum quality, okay? We'll go ahead and test those. All right, so it's just pointing at the epithelial cells, the mucus, and then the bacteria. White blood cells. All right, so here it's just showing the different features between pneumonia and tuberculosis. We'll get a little bit more into that tomorrow. This is just an introduction to this, all right? Tuberculosis, you're gonna have that AFB stain culture, no Bartlett scale, but with pneumonia, we will use that Bartlett scale. And we'll talk more about this tomorrow. And then the nucleic acid amplification test, or NATs. Really the most common ones that you all will be associated with those PCR. Okay? So key features, thermal cycling amplifies the DNA. It's best used to detect DNA in bacteria and viruses. It's high sensitivity and specificity and requires very expensive equipment that we use in microbiology. The rest we will not be talking about. Okay, check on learning. You receive a lab report on 2 stimulated patients. 1 out of 8 blood culture bottles for each patient is positive for that coagulase negative staphylococcus, often a normal flora skin. Is it a contaminant or a real infection? So patient 1 has no central line, and they only have one, they're meeting 2 of the SIRS criteria. And then patient 2 has a central line, and they're meeting 2 of the SIRS criteria. So would you treat these patients, or do you think they would have contaminants? So let's look at the, according to this. They both had 2, right? Treat them. Yeah. Say it again? Yes.
You treat
Both.
both.
No, you don't treat
Okay, so they meet 2, right? So this first one has no central line, right? And temperature, they meet the first 2.
With no central lines, they would need
They would need 3. They only have one positive blood.
So I'll come up with some more questions. We'll have to go more into this tomorrow, because I know I have a couple questions on the test for that. And I want to make sure everyone's clear, and I got to be clear, okay? Let me write that down.
Central line? What is or it is? What does that mean?
So that means you're putting it into a central blood vessel. So like your normal IV stuff, they're not central, they're peripheral. Central means they go straight to the heart.
So, yeah, if it is central line.
Okay, so now we're at ELO.
Yes,
But I'll make sure it
so
gets,
for the section, you put like stuff that
here's some questions I have.
So it would be just highlight that means.
Okay,
Yeah.
so that is it for this one. We're moving on to the next one very quickly. There's only like 35
Right now,
slides.
now you've been going
Okay, so
from
you
the
break,
central environment straight to the heart. So now
go pee, go poop, go get some drink, and we'll come right back into this.
reasons why you
Okay?
can't have central line.
So then, you would treat it.
Yeah, that's what algorithm is 2 certain criteria. You can treat the central line one, but the one that doesn't have a central line, it should be contaminated.
Oh, I see. Okay, central venous catheter, that's the central line.
Yeah, so do they have one? Yes, no. One of them did, one of them didn't. So yes.
Oh, I see.
Yeah.
Okay, thank you.
Yeah.
Maybe not. Basically, mid-shaft, maybe you do 3/4 down, cut the femur, right? So good to have a femur, hollow it out, remove the growth.
I mean, you really had to like.
The mid part of it. I think when this is this rocket, the middle, and flexible vascularization on the femur. Shove it inside of the cadaver femur.
Yeah.
And then put it back in. Rose, she's not cutting. I think it really needs it.
Rubber is all.
Think about it. You feel it too much. Because then taking your like emergings, you know, and like left and distal one. And just show me a picture of this like disgusting looking fibula.
Yeah, like I didn't put mine. Like sometimes I just like no, they don't have to.
Gangs that are crazy, like a tornado. Yeah, like a sausage tornado, whatever. Heck yeah.
My wife didn't do that too. How old you are? And she's all like, you better take the ball and get like this ball. I'm just like, no, still just waiting.
But it can be used for other stuff. I don't know if I can do that.
Yeah.
Pictures of the surgery. Cut it open.
You better be praying to your
just fibula. It's like some this is revascularize the bone. It's like, oh, basically just a stabilizer. Making blood. But it's still
You have read that. Why do you think it's leaning on
It's so weird. I asked, my thought process was, okay, it's going to, osteoblasts are going to re-elevate, and it's the roaster growing
I
together.
don't do all the sacraments, but I haven't been practicing.
I just trigger them.
I'm not. I have my own like issue with like religion, but like I grew up Catholic, like I went to all the Catholic. Married, but like I didn't understand. Well, yeah.
Not everyone. It's hard though because you have to be affiliated with.
Yeah, like
And you have to go to all that. But he's in the military. He travels and.
it's hard to get married in the Catholic Church. Like it's stupid hard. Like so. No.
He's agrees.
Plus my wife has fun, so I'm not gonna. I'm not religious, so I'm not gonna go to all that shit married in the church. Because
I had a dermatologist that was
It was good. And so they had like probably 3 or 4 locations.
it's not good. Yeah, it's like that's like good. That shouldn't be.
I think for this one.
No, I was like it's not good. I know I can tell you.
Yeah. Was it
You know, like, we're watching it. And you know the acid that plays Bronco? The Steam production?
Oh yeah.
So I've been watching it all like, I bet she's crazy. She's like, you guys like Alabama? So I look it up and like, yeah, she's diagnosed with ADHD. I'm just like, I know she's now.
Everyone loves her.
She died in recently. Yeah, 24. But she was older. Like, she died like.
She was around for a long time. A lot of those like stuff like
Oh yeah, she's good at acting.
It was pretty damn tight.
I think she's one of the I think she's one of the like outbreak ceremonies.
What type of people they are.
Yeah, I didn't got it.
Little.
Go to church.
Yeah.
Is that
That's like,
Little guy. It's more like an elf.
The little elf.
like an elf?
An elf. An elf.
even if we like watch
In like
and they run as a duo thing.
It's like yeah.
So many people, I'm like, yeah,
Wearing like a it looks like a rag. It looks like a rag. Like a rag is yeah.
So this was how it was on. So like we're super expensive. So public keratitis. So
it was a $10 corn dog, $5 better.
where else have you seen it?
Shared a big.
I think this is never seen it. Yeah, it's like 2 reviews.
You can knock out these 38 slides.
That's all.
I know.
Time now.
Huh? That's all. One day.
All right. Okay, so here's number 2, microbiology 2. Now we're going to be focusing more on urogenital, skin, and soft tissue infections. So SSTIs. This is our very graphic slides today. TLOs and ELOs. So we're going to be going over urethritis, cervicitis, vaginitis, genital ulcer disease, syphilis, herpes simplex, HPV or PID, pelvic inflammatory disease, infections, and HIV exposures. Okay, this comes from your reference, chapter 57 and 65. All right, here's our clinical introduction scenario. A 28-year-old presents with genital ulcers. purulent urethral discharge in dysuria. A gram stain of a urethral swab reveals PMNs with intracellular gram-negative diplococci, confirming gonorrhea. Additional PCR testing detects HSV2, herpes simplex virus 2, from the ulcer swab. The provider initiates appropriate antibiotics and antiviral therapy while counseling on STI prevention and partner notification. Okay? This is our agenda. So we're gonna go over our microscopy, our PCM, our provider performed microscopies. Y'all remember what wet mounts were, right? What are they? Right, when you do your wet mounts, when you're, well, we had talked more about collecting from vaginal swabs, but you can also use it for things that are on the skin as well. We're talking about KOH prep. What are we looking for in a KOH prep? Fungals. We're going to talk a little more about zinc prep. Yeah, it is not common, but it says here it's going to be on your pantry, so you need to know it. Talk about whip testing and gram staining. Then we're going to go a little bit more into urinalysis. We talked a lot about urinalysis last block. We're going to do a little bit today. Culture and sensitivity, your nucleic acid amplification test, rapid test, and serology testing. All right, so provider perform microscopy. All right, y'all know wet mount, KOH, whip test, urinalysis, and comprehensive testing, microscopy, NAT for molecular diagnosis, and rapid test for immediate results. You see this a lot in urinary tract and STD infections. You all will see this a lot in your MTFs. Okay? All right, so this is an important slide I want you all to know. All right? So in wet mounts or in saline wet preps, we're looking for things like trichomonas, clue cells, which is indicative of what? Do you remember? Bacterial vaginosis, and then those fungal elements, we're looking for those bloody knees. All right? This is usually performed within 20 minutes. All right? Your KOH prep, we already talked about, we're looking for the fungal. And then, yeah, I think y'all have this because I have tested y'all quite a few times on this, but let me test you again, I guess. All right, so saline plus a sample and a cover slip, right? So those clue cells, you see those clue cells in there with all that bacteria on there. You have those trichomonas, they'll move around with, have that jerky, and move around and have like a jerky motility. Then you have the zinc prep, which is used in a GIMSA stain. And then KOH for fungal or whip testing. Right? So in whip testing, you're mixing a drop of discharge with a drop of 10% KOH. And usually it'll produce that fishy odor, which is suggestive of feeding infections. Right? So there is a $ on here. I don't have any questions for you on it, but just know it, because you will see it again, okay? Gram stain, this differentiates the gonococcal versus the non-gonococcal, okay? So gonococcal urethritis or cervicitis, gonorrhea, all right? The findings will have those neutrophils with intracellular bacteria, so there's just bacteria within those cells, pretty much what that means. And then the non-gonococcal urethritis or NGU, you'll see this in chlamydia, and those neutrophils will not have the intracellular bacteria. That bacteria will be outside of those cells. All right, so here is some ways to collect for urethritis or cervicitis. You have a swab collection. This is suitable for that gram stain and culture. It says self-collection is convenient. Please don't have them collect themselves. You collect the samples, please, because it will not, we will not receive it correctly. So you have your urethral discharge. The swab technique collects the discharge for the gram stain culture and molecular diagnostics. And then yet urine, that first void, you want a minimum of 3 mLs. Okay. Saying a lot of the same stuff over and over. So gram stain identifies the clue cells and epithelial cells covered in bacteria. Urinalysis, I think we have talked about urinalysis so much. So the most common for routine patients is what type of urine? Right, clean catch is the most common. Your catheter or Foley is unable to, for those that are unable to void. And then you have your suprapubic aspirate, primarily for those neonates, for the babies. All right, so dipstick analysis, we talked about this. Nitrates, you're looking for the bacteria that converts to nitrites, and then your leukocyte esterates are your white blood cells, right? An indication of some type of infection going on. Likelihood of a UTI or hematuria. All right, so for the sake of microbiology, you see on that top corner there, that is the Petri dish. And so when we get those urines back in microbiology, we'll take our loop there, we'll dip it into the urine, we'll put one streak down that Petri dish, and then we'll just kind of do this motion here, right? And pretty much we'll wait 24 to 48 hours, let it incubate for that amount of time, and we'll see what type of bacteria grows, okay? So if there's no growth, there's likely no infection, no further workup. But if we have, in a clean catch, if we're seeing greater than 100,000 CFE per mLs, and there's one single organism, then we're suspecting there's something going on. But if there's less than or equal to 5,000 CFUs per milliliter of a single organism ID, ID and susceptibilities will follow up, okay? If we're seeing a whole bunch of we call mixed flora, if we're seeing 3 or more different types of colonies, then we are suspecting some type of contaminant. It's pretty much all this is saying here. Correct. So cystitis is the inflammation of the bladder from infectious or non-infectious causes, and UTIs are from the urinary tract, right? All cystitis are UTIs, and all UTIs are not cystitis. Okay, cystitis is typically a nuisance, often seen in women, causing discomfort, and UTIs indicates broader infections. Potential complications if not treated. And you see how I'm like kind of going really fast through this because I'm not going to test you. I haven't overly test you all on UTIs, but this one is important. Genital tract infections. Clinical presentation, indication of HSV or herpes simplex virus. Ulcers are caused by HSV, syphilis, and chancroid, chlamydia L1 through 3, and zoonotophonosis. Okay? So anytime you suspect genital tract infections, you want to collect for gram stains. We will perform dark field microscopy. This is used in syphilis. We'll do PCRs. We'll detect the herpes and chlamydia, and then serology we use for syphilis. And typically a culture is not used. It's not really effective for syphilis, and it can be challenging for chlamydia. So we will, for the lab, for the sake of lab, PCR, microscopy, and serology, you will get those reports back for any genital tract infections. Okay, so SSTIs is skin and subcutaneous infections. So a lot of clinical presentations can include vesicles, bullae, or pustules. You can see cutaneous ulcers, which is those openings in the skin. There may be some type of rash of unknown origin, or abscesses, which is like have local pus collections, and cellulitis, which is inflammation of the skin and subcutaneous tissue. Now, if you see an open ulcer, where are you collecting that sample? From the edge or from the middle? Where are you collecting it from? In the center. That's what we need, that active site. That is what we're looking for. Okay? And we could identify maybe it could be fungal, bacterial, viral, or parasitic. All right, fungal infections, diagnostic approaches, ID and confirm SST fungal infections. Again, gram staining. You could provide some biopsies if needed. You do skin scrapings or KOH prep, which you can do possibly at the bedside. And then you can also identify fungal elements with a Woods lamp. And we'll talk a little bit about that in the next couple of slides. All right. So fungal culture collection methods may vary based on the site and the type of specimen. So an abscess, you want to collect about 1 to 5 mLs with a needle and syringe. Okay? You want to transport in a luer lock cap syringe without the needle. So when you submit that to us, please remove that needle, place that in the sharps container, put the rest of that, the actual abscess itself into that biohazard bag and submit it to the lab. So you have your biopsies. What were the two that I told you to remember? How to take a biopsy?
Sample.
Punch and shave, yes, okay? You want to collect 1 gram of tissue in a sterile container with a few drops of sterile water. So with hair, you want to make sure you collect the shaft and the base. So you gotta pluck it off, okay? Nails, we will test nail shavings, especially for any fungal elements that are found on the nails. And then for swabs, inferior specimen, you want to use specific fungal swabs. So please don't provide those cotton tip swabs. There are specific swabs needed for fungal elements. Okay, so for skin scrapings and KOH preps, skin scrapings, especially from the lesion's border, are crucial for accurate diagnostics of fungal infections. The subsequent KOH prep aids in identifying specific fungal elements. All right. So, specifically for the skin scraping or KOH prep, you want to make sure that you're taking it from the border of that lesion. And so I will make sure to, so if you think it's fungal, from the border. If it's viral or bacterial, make sure you get it from that active part of that lesion, okay? I'll make sure you know the difference between the two. This is also another good slide. All right, I will test you on this, and then you will learn a little bit further when you get to dermatology in your senior year. So Wood's lamp in dermatological diagnosis, this enhances the diagnostic accuracy by highlighting the fluorescent pattern in skin infections. Okay, so not all fungal or bacterial infections will fluoresce, but this Wood's lamp does help with that, okay? So Tinea capitis, or that fungus that's found on the scalp, will fluoresce blue-green. For body fungus, Tinea corpus will fluoresce faint green, and then for bacterial infections will fluoresce a coral red. And then lastly, that vitiligo will have that milky white fluorescence. All right, so make sure you have highlighted that slide and know the difference. And here's some visual representations of that. So that Tinea capitis looks very blue. That erythromycia, it's got that reddish look. That Tinea corpus on this gentleman with the mustache there has that light blue with that Wood's lamp, and then vitiligo has that milky look. And vitiligo can be really obvious even without the Wood's lamp. Okay. All right, so microbial testing, culture and gram staining will grow in a test tube with that thioglycolate nutrient broth. So you all are not providing the broth to us, we already have it in the lab. So for your aerobic culture, the bacteria will grow at the top. So pretty much it's just like a tube, it looks like a broth. It looks like regular chicken broth or whatever. And the aerobic culture, the bacteria will grow on the top. For the anaerobic culture, the bacteria will thrive at the bottom. All right, and usually, and how long does it take? What was the amount of time, do you remember? 24 to 48 hours, yeah. All right, viral skin infections diagnostic approach. So PCR for herpes and poxvirus. For your zinc smears, we'll examine those ulcer scrapings for giant cells that we will look for. It's a quick test for herpes as well with that zinc smear. For serology, we're looking for antibodies and for past and current infections. And then for viral cultures, it's less frequently used for culturing viruses from skin lesions, but sometimes it is an alternative method. And then smallpox, that is, you suspect smallpox, please let the lab know, because we have our own criteria that we have to do as well, and we have to also report that up to the state as well. All right, so transport media for viral cultures, you'll have, it depends locally, right? So per their SOP, per that lab, we'll let you know what that is. For fluid aspirations, you want to use a syringe for intact vesicles. For lesion scrapes, you want to collect from the base of that fresh lesion for the viral swab. And it's important of freshness. So make sure you're getting it to the lab as soon as possible. And if you cannot, make sure that you are putting it in the refrigerator until you get it to the lab. All right, so zinc smear, this is for viral infection diagnosis. All right, so in the zinc smear, we're looking for those multinucleated giant cells, which are diagnostic for herpes. And yeah, that's all we need to know there. So those are just those giant multinucleated cells. That's what we're looking for. Serology, we're detecting viral infections. So we're looking for antibodies in the blood. And we're going to talk a little bit more about that tomorrow. The key application here is that it confirms the immune response. So it's for viruses like hepatitis and HIV. If we're seeing an immune response, then we know that they got something going on with them, right? Serology-wise. Primary HIV infections and rashes. So primary HIV occurs soon after exposure and often with a rash. And that window period can vary between the exposure and the detectable infection, okay? So key tests, these are important. Key tests are important, all right? NAAT detects HIV 10 to 33 days post-infection. Antigen and antibody detects HIV infection 18 to 45 days after exposure, and then the antibody test detects 23 to 90 days post-infection. All right, so diastopy or blanchability tests differentiate inflammatory versus hemorrhagic skin lesions. You want to apply pressure with the finger or glass slide on the lesion itself. So blanching is positive. The inflammatory lesions often indicate allergic reactions to autoimmune conditions. And in non-blanching, that means that it's negative, and those hemorrhagic lesions suggest a more urgent condition. So this is just good to know introduction information. I said when you become seniors, y'all gonna get deep into this. That's why I'm kind of like, going over it quickly. And then parasitic infections in the SSTI. This is based on observations of the symptoms. All right, the skin scraping samples will confirm the clinical diagnosis. And for parasitic infections, we do the GIM sustaining. All right, and so we will collect that skin sample. We'll apply the GIM sustain. We'll look at it under the microscope, and then we will identify the parasite and their features. Okay, and that is it for that. All right, so really all I wanted you all to get from that is understanding how to collect, right? What to collect and where it's going in microbiology. Like that is it. This is going to be such an easy test for y'all. Any questions, concerns, complaints, gripes, none of the above? That's it for me today. I will see y'all tomorrow.